everybody. How are you? Okay, so I understand that a lot of you can't hear me. We do know that that is a situation when people are speaking through their masks. But how important is it? Remember what I said the last time I was in front of this camera. When I do not have this mask on, I could actually see spray coming out of my mouth. And if there's spray coming out of my mouth, probably when you speak, you also have spray coming out of your mouth. And what is it that you need to be doing? You need to be protecting those around you because you just never know what you're passing on. So it would be best if you stay protected, okay? I will say it 1,000 more times if I need to, but that's where we're going to stop for right now. Okay, so let's get going here. For those that don't know, my name is Stuart Schlossman. I'm president and founder of MS Views and News. And why are we here today? Well, to tell you the truth, we were supposed to be in Roanoke, Virginia today. But what happened? COVID. COVID happened, all right? And what happened in Florida? Well, Florida's a hot spot right now, right? So those of us that were going to be going to Roanoke to be doing this educational program learned that the people in Virginia really did not want Floridians going there. So we're staying in our own state. We're staying in our studio that we have there where we do a lot of these productions from. And we're providing this program for not just those in Virginia. Hi, guys. How you doing? I'm really sorry I'm not there, though, all right? Really, really sorry. I really wanted to be there, and you all know this, too. But we also picked up a very large virtual audience doing this program. So we're doing this event today, okay, live from Longwood, Florida. Okay, we're doing it for those that are in the audience in Roanoke, Virginia. They're enjoying a nice dinner. I hope you take a few bites for me as well, all right? And we also have our virtual audience. Okay, and for tonight's program, I hope you can see that we have quite a few sponsors, all right? We have Sanofi Genzyme, we have Genentech, we have Novartis, and we have Bristol-Myers. And I hope that everybody can appreciate what they're doing, and we can, give them a round of applause virtually, all right? Yay! Here we go. All right, so what else we got going in Florida? Well, we got a coming hurricane. So we thought that was going to be a problem for tonight, which it's not, fortunately, and we could do this event. We don't have to worry about any rain so far. Tomorrow morning, remember, for those that are watching this tonight, tomorrow morning we're doing this same program again. And it is basically the same program. Our presenter, Megan Weigel, may throw in a few new things. I really don't know. That will be up to her for tomorrow. Okay, but for tonight, she's going to speak about the topics that we've already announced and you've seen on the flyers, and I'm not going to get into that. What I do want to get into is just speaking about Megan. All right? Megan Weigel, she's a doctor and nurse practitioner specializing in neurological care in Jacksonville Beach, Florida, where she brings a unique integrative medicine and holistic nursing perspective to her practice. First Coast Integrative Medicine is the name of her practice. She earned her doctorate of nursing practice from the University of Florida when her research emphasis was on preventative health care. Megan is the co-founder of OMS Yoga, a nonprofit organization that brings free yoga classes to people living with multiple sclerosis along the East Coast. And before I ask her to come up, I just want to let you all know again that her talk is somewhere about 45 minutes, following which we'll be doing the Q&A. For those that pre-registered, I know that a lot of you ask questions online. We will be addressing those questions. For those that are in Roanoke, we will be calling you, and we're going to call you before we get to the virtual program. The virtual questions. We're going to call you to get your questions. So if you want to leave that room earlier, you can, all right? But we'll get to your questions first, and then we'll do the virtual. For anybody that's online watching this virtual event, you can ask your questions online, all right? They're in the on your screen. You'll see where you can look at the questions. All right, and then just type in your questions. I'll get your questions, and then we'll go forward from there. All right. So again, thank you for joining this MS Views and News program. We are #1 in virtual events. Thank you very much, and let's now welcome Megan. There you go. You can come right on up. Oop, let me step 6 feet away.
Hi, everybody. Thank you for joining us virtually. I know that a lot of you probably have Zoom fatigue, virtual fatigue, and I think it's great that some of you in Roanoke do get to be together safely in a physically distanced manner. I agree with Stu that wearing the mask is really important. I've got a cute one with neurons on it that a scientist who I'm involved in a study with for MS made for the investigators. So without further ado, I don't have too much time, and I have a lot of really important things to talk about. So let's move forward. Tonight's objectives are to define MS relapse and outline treatment options for relapse, become familiar with the names, mechanisms, efficacy, side effects, and monitoring parameters for our current disease-modifying therapies, give you guys a little bit of perspective about living with MS in the current COVID-19 pandemic, and then talk about the value of integrative medicine in MS care. First, we're going to really briefly touch on MS relapse and relapse treatment, and I say briefly because for those of you who are new to MS, you are very likely not having relapses very often because of the efficacy of our more modern disease-modifying therapies. For you, those of you who have been living with MS for a very long time and might be in more of a secondary progressive stage, you may not be experiencing relapses as often as you did when you were in a more inflammatory, call it younger phase of MS. But I think it's really important to define the difference between relapse and pseudo-relapse, because what does happen, especially right now with the amount of stress that we're all under, is an increased frequency of pseudo-relapses. So let's talk about that. A relapse is a new neurologic symptom or increased severity of an old neurologic symptom that lasts more than 24 hours, and some literature even says 24 to 48 hours. And it cannot be explained by anything else. So it can't be explained by an infection, by heat exposure, by fever, by stress, by, well, I guess none of you have relatives visiting right now just because of the time. But in any case, it's something that really makes you step back and say, this has not happened to me before, or this has not happened to me in a long time. A pseudo-relapse is an increase in severity of a neurologic symptom that you've had before. And typically, the cause of the increase in severity is either an infection or fever, exposure to heat or increased physical exertion, increased stress. Maybe you've had medication changes. Maybe you have another medical condition, say, for example, diabetes, and you're having blood sugar fluctuations that affect you neurologically. Also, excessive alcohol use. Maybe you're a female, and actually women who live with MS tend to have fluctuations in symptoms just prior to their periods with PMS. Maybe you're just tired, tuckered out, right? So all of these things can cause your underlying MS symptoms that you're used to flare up, and that would be called a pseudo-relapse. Treatment for relapse is typically steroids, and it's 3 to 5 days of IV methylprednisolone or even high-dose oral steroids with tapers, also ACTH or Acthar gel, and in very severe cases, plasma exchanger IVIG. When we treat a pseudo-relapse, we treat the underlying problem. So if you have an infection, most commonly in MS would be a UTI or urinary tract infection, we treat the infection. If you're overtired, overstressed, we prescribe rest. If you're overheated, we talk about cooling equipment. We talk about staying well hydrated. Maybe you need an adjustment of your medications to try to help your symptoms get better. And for both relapse and pseudo-relapse, we do talk about rehabilitation like PT, OT, speech therapy, and behavioral modifications to help your symptoms improve. Now let's move on to the real meat of the talk here, which is MS disease-modifying therapies. And the reason, again, that I was able to breeze through the relapse part is because of how our treatment paradigm has just exploded in MS in the past, I'm going to say 10 years. When I started as a nurse practitioner in multiple sclerosis, it was 2001. I was able to work with Avonex, Betaseron, and Copaxone, and shortly into my career, Rebif was approved. So we had drugs with 2 mechanisms of action, and if one didn't work, then we went to the other, and if the other didn't work, then maybe we went to a high-dose interferon. But now we've got this armamentarium of medications that we can use to treat people living with relapsing MS. And it's almost, it's amazingly hopeful, but then at the same time, it's overwhelming because one of the most frequently asked questions these days is, how do I know how to pick a medication? How do I know which medication is right for me? Well, this list here talks about what helps guide the decision, and this decision should be shared. It should be a shared decision between you, your support system, and your MS care provider, your MS care team. We talk about disease status. How many relapses have you had in the past year or two? How much MRI change have you had in the past year or two? Are you having worsening disability, motor disability, or cognitive disability? Are your symptoms getting worse? We talked to you about medical comorbidities and past exposure to other disease-modifying therapies, either for MS or perhaps for another autoimmune condition or even for cancer, because that may help us take some disease-modifying therapies off the table and leave us with a smaller pile. We talk about your risk tolerance. So as a person living with MS, how much risk are you willing to tolerate for benefit? For example, a highly efficacious therapy may have more risk to the immune system, risk for infection, risk for certain types of cancers. And that may be something that you're just not willing to tolerate, whereas other people say, give me the strongest therapy and I don't care what the risks are. Another type of risk tolerance is the risk tolerance of your MS provider. And you might say, well, what does that mean? Well, many MS providers are more conservative than others. They're much more cautious about prescribing newer therapies, or maybe they had an unfavorable outcome with a therapy, even if only once. And that can influence the medications that they're comfortable prescribing. Also, the knowledge of the MS care provider. And this is why we talk about in the MS community the importance of comprehensive MS care and MS specialty care. If you're seeing a general neurologist in your area, that general neurologist may not be as familiar with the whole armamentarium and all of the nuances of treating MS. That doesn't say, I'm not trying to say anything negative about a general neurologist, because I am completely certain that I would feel the same way about treating epilepsy, as I'm an MS specialist, not an epilepsy specialist. But there are so many medications now that unless you are entrenched in multiple sclerosis, you, again, may not be comfortable with the newer ones that are coming on board, or even some of the older ones that have more risk. And so if you are in a community where there isn't an MS center, you may want to consider going to get a second opinion to make sure you're on the right therapy. Other things include insurance, and unfortunately we have to play that game. Some insurances still have step therapy, where they require you to try one drug before you can take another one. Also, your support system. If a medication requires you to access the healthcare system or other specialists for monitoring, we want to make sure that you are supported by your family, your friends, and your work so that you can do that. Route of administration can matter. If you have issues with dexterity, with mobility, or with transportation, then we don't want to inflict hardship. We want to find ways around those things so that you can get your medication the easiest way possible. And then financial status, how expensive is the medication? What's your payer position? So do you have commercial insurance or a government plan? And then what assistance is available? So you can see this is a really complicated decision, and it gets more complicated. What I'm going to do is I'm going to really quickly breeze through these slides so that you can see what we're dealing with in today's MS treatment environment, and then I will back up. So these orange slides are the current available treatments in MS. And I was thinking about it this morning when I was packing to drive down here, that when I started 20 years ago, we'd have one slide to talk about. 45 minutes would be nothing. In relapsing MS, our disease-modifying therapies aim to alter the natural course of the disease. The primary and secondary endpoints for most clinical trials for disease-modifying therapies in relapsing MS are annualized relapse rate reduction, decrease in MRI markers like new T2 or expanding T2 lesions, gadolinium enhancing lesions, and then delaying disability progression. one of the things that we aim for in multiple sclerosis is no evidence of disease activity. And there are certain parameters for that. The NEDA goes from 3 to 5, and I think even beyond that if you really want to get into the nuances of it. But we don't have a way of choosing the right medication for Mary, the right medication for Bob in the sense of a biomarker right now. So we have to go on these decisions here, what guides the decision to choose the best medication that we feel and you feel will help your MS the most. So let's talk briefly about our first generation injectable therapies. We basically have interferons and we have glutarimer acetate or Copaxone. Interferons can be low dose like Avonex, which is given once weekly, or high dose like Betaseron and Rebif. Also, Plegridy is more of a low dose interferon, like a way of giving Avonex in a prolonged, different pharmacokinetics. So these medications, the interferons, have anywhere from 31% to 38% reduction in relapse rate. They do a fairly good job with decreasing lesion progression, gadolinium enhancing lesions, and T2 lesions. And they also do they do fairly well with relative reduction in disability, so about 30% relative reduction in disability. Interferons are associated with injection site reactions, flu-like symptoms, liver enzyme elevation, and white cell decreases. And we need to monitor blood count, thyroid, and metabolic panel, specifically liver enzymes, when you're, that's perfect, Phil, thanks, when you're on these medications. Glutarimer acetate does not require any monitoring from a laboratory standpoint, but we do have to look for injection site reactions. We do have to ask you about what we call the Copaxone flush, so it's kind of like this hot feeling. You may turn red that has no rhyme or reason to how long you've been on the drug. It's not an allergy, it just happens sometimes. And then lipoatrophy. So for those of you in the audience who've been on Copaxone, you may have little divots where you injected a lot over the years. By and large, our injectable therapies change the way that T cells work. So interferons decrease T cell activation and proliferation, and we think that they block T cell migration across the blood-brain barrier, which means T cells don't have a chance to attack the central nervous system and cause inflammation. Glutarimer acetate activates Th2 immune cells, which are anti-inflammatory cells, and they enter the central nervous system and actually cause an anti-inflammatory cascade. So these drugs are primarily T cell drugs. And back 20 years ago, well, we were fairly sure that MS was a T cell disease, just like we were fairly certain that MS was a disease of the white matter. And we now know that MS affects T cells and B cells and white matter and gray matter. So let's move on to oral medications. I do want to give a disclaimer here in that I did not list all of the outcomes of all of the clinical trials. Many of these drugs have been compared to both placebo and to an active comparator. I chose the placebo data when it was if there was an active comparator, and I'll let you know if there is no placebo data during a study. I'd also like to say that it's almost impossible to do cross comparisons of the endpoints in the clinical trials between or among the drugs because the clinical trial populations look different. The way that the statistics are presented are different. So the numbers I'm giving you here are meant to be taken a little bit with a grain of salt. These are our oral medications, and I'll start with the S1P receptor modulators as a class. Our oldest one is Gilenya or fingolimod. It's approved for relapsing forms of MS, 54% relative reduction in annualized relapse rate, 30% reduction in disability progression risk, and then a very good job with shutting down MRI. However, there are risks associated with it. So we have to do first dose monitoring with Gilenya because of the risk of bradycardia. We need to have you see an eye doctor before you start the drug and about 3 to 4 months in because of a very small risk of macular edema. We need to have you see a dermatologist before you start the drug and at regular intervals because of the risk of basal cell and other skin cancers. And on a regular basis, we're monitoring your blood count, your liver enzymes, and also your JC virus antibody status, because there have been cases of PML associated with fingolimod, as there have been cases of CMV meningitis. So before you start this drug, you have to have an EKG, an ophthalmology evaluation, lab work, and a dermatology evaluation. The things that I'm recommending in monitoring may be in excess of what the prescribing information recommends, and this is based on my practice and some of my colleagues' practice. Siponimod, or Mayzent, is one of the newer S1P receptor modulators, and this one's more specific than fingolimod, affecting just S1P1 and 5. These drugs as a whole sequester lymphocytes in the lymph nodes. So what they do is they latch onto this receptor, and this receptor typically is what allows lymphocytes or white blood cells out into the bloodstream. When it latches onto the receptor, those lymphocytes stay in the lymph nodes, and it's only certain types of lymphocytes, so you do still have a surveilling immune system, which is why these medications lower your white count, but they do not bottom out your white count. Mayzent was studied in relapsing forms of MS, but specifically the population in which Mayzent was studied was really an active secondary progressive population. So these people were older, they had MS longer, they had a higher level of physical disability or a higher EDSS score than folks in the fingolimod study. Their outcomes were relative to those as the study population as a whole, but specifically to people with active MS, there was a 55% relative reduction in annualized relapse rate, an 81% relative reduction in newer enlarging T2s, 86% in gadolinium-enhancing lesions, and a 23% relative reduction in brain volume loss. What you're going to see as these trials become more modern and the drugs become newer is they have additional secondary outcome measures, specifically things that we know how to do now, like measure brain atrophy, brain volume, look at cognitive measures of disability, not just physical measures. The monitoring parameters are the same for fingolimod, except there's also genotyping. So the pharmacokinetics of this drug state that a person needs to have CYP2C9 genotyping without a star 3. If you have CYP2C9 star 3, the drug is contraindicated. If you have 1 star 3, you require a different dosing schedule to start the drug and stay on it. Siponimod or Mayzent does not require a first dose monitoring unless there's a reason to do that, and a pre-screening EKG would let you know that. The newest S1P modulator to the table is Zeposia or ozanimod. It was approved literally just a few weeks ago. It's also an S1P1 and 5 receptor modulator. There's a 48% reduction in annualized relapse rate, and you might say, well, that's lower than the other ones, but this is compared to Avonex. So compared to an active comparator, a good drug, a gold standard drug. 63% fewer gadolinium positive or enhancing lesions versus Avonex. This drug also does not require a first dose monitoring unless the pre-screening EKG, which is recommended, suggests that you should do so. Lab work is the same. Side effects or adverse events are, at this point, a little bit less than what we know of fingolimod, as are Mayzents, and you can see them up there. Other oral medications, I'm going to talk about dimethyl fumarate and diroximel fumarate at the same time. Tecfidera and Vumerity. Vumerity is an isomer of Tecfidera that was developed to hopefully allow for fewer side effects, GI side effects of the medication. These drugs both cause an inflammatory to anti-inflammatory shift in T cells. They cause apoptosis of lymphocytes, which means that lymphocytes come apart. And they also activate an antioxidant pathway called the NERF pathway. These are approved for relapsing forms of MS, depending on what study you're looking at, have between a 44 and 53% relative risk reduction in annualized relapse rate, do a good job shutting down MRI like most of our therapies do, and have a relative reduction in disability progression of about 38%. Side effects of Tecfidera more than Vumerity are GI, you name it, it's in there. Bloating, nausea, diarrhea, constipation, weight gain, weight loss, dyspepsia, indigestion, and also flushing. And we tend to help you with those side effects by telling you to take aspirin, certain GI medications we might recommend. And most people do well once they've been on the drug for about 6 to 8 weeks. Also lymphopenia, which is a decrease in white count. This may be prolonged. And that prolonged lymphopenia can affect our choice for a disease-modifying therapy later. There have been cases of PML associated with Tecfidera, as there have been with the S1P modulators. I think I just put that under fingolimod because Mayzent and Zeposia have yet to have a case of PML. Only fingolimod has had cases of PML at this point. With Tecfidera, we monitor your blood count, your metabolic panel, and also we check your JCV antibody status prior to taking the drug and probably every 6 months along the way, depending on your age and prior exposure to disease-modifying therapy. Moving on to teriflunomide or Aubagio. This has a different mechanism of action. It inhibits the enzyme dihydroorotate dehydrogenase, which inhibits rapidly dividing T and B cells in your lymphocyte, in your bloodstream. And by doing this, it slows down part of the immune response, the rapidly dividing part of the immune response, but it allows the slower immune response to continue to happen. There's a 31% relative risk reduction in annualized relapse rate. 80 to 84% of people are free from disability on this medication over 108 weeks. There are 80% fewer gadolinium-enhancing lesions and a 60% reduction in total lesion volume. When you take this drug, you need to have your liver enzymes monitored monthly for 6 months. You also need to be checked for tuberculosis, and you can do that with a blood test now. It doesn't have to be the little skin prick test. And pregnancy. We monitor liver enzymes. We ask you about hair thinning, nausea, diarrhea, and headache, which are the most common side effects of this medication. I'll add here, because I'm talking about it as we move forward, I did not mention pregnancy in all of these drugs because as a rule, we tend to recommend people stop disease-modifying therapies prior to becoming pregnant. However, specifically medications like Aubagio, Mavenclad, Ocrelizumab, and alemtuzumab, Lemtrada, or Ocrevus, and then the S1P receptor modulators, we definitely want you off of those drugs prior to becoming pregnant as let's just say the orals and IV therapies. We now have data that tells us that interferons may be fairly safe in pregnancy. We think Copaxone is safe in pregnancy, and some folks are even doing extended interval dosing of Tysabri during pregnancy, depending on the status of the woman's MS. So let's move on to cladribine, also a newer oral therapy on the block. Cladribine is given in 2 cycles of 4 to 5 days. It's a weight-based therapy. So you take it 4 or 5 days in a row, and then at least 23 days later, you take it another 4 or 5 days in a row, and then you're done with treatment. So this isn't a daily treatment. This is like something that you do once over let's call it a 32-day period, and then you're done with your MS treatment. Cladribine impairs DNA synthesis in TMB lymphocytes, and this results in their depletion. There's a 58% relative reduction in annualized relapse rate, 33% risk reduction in disability progression, and again, a good job with MRI. We tend to do really well with our newer disease-modifying therapies and MRI. This medication is associated with lymphopenia, malignancies, infections, liver injury, heart failure, upper respiratory infection, and headache. By and large, these side effects are uncommon. We monitor CBC, we monitor metabolic panel, and before you start the drug, and probably every year or two thereafter, we'll check an HIV test, hepatitis B and C exposure, a TB test with quantiferon gold, and a pregnancy test. Also, with many of these medications, we're making sure that you have antibodies to chickenpox before you take them, because if you don't, you need to be vaccinated, and then the start of therapy needs to be held off at least 4 to 6 weeks. IV medications. The one IV medication that I left out of this presentation is mitoxantrone because it's rarely used these days. I'm going with the things that we use most frequently. And the oldest kid on the block is natalizumab or Tysabri. It's a monoclonal antibody that blocks T-cell migration into the central nervous system. It's been studied in relapsing forms of MS. You can see that there's a higher level of relative risk reduction in disability progression. There's a higher level of relative risk reduction in annualized relapse rate, and it does a good job at MRI. The most common side effects are infusion reaction, which is uncommon, hypersensitivity, also uncommon, elevated LFTs and liver injury, and then the one that worries most people is PML, or progressive multifocal leukoencephalopathy. So we're monitoring blood count, metabolic panel, and that JCV antibody status on a regular basis with this medication. ALM2, which is it's given monthly. And now we also, particularly in the COVID era, have become more interested in extended interval dosing, which tends to be about every 6 weeks. Alemtuzumab or Lemtrada is another, I'm going to call it short-term therapy. Most people get 2 courses of this therapy, 5 days 1 year and 3 days the next year, and then they're done. It's also a monoclonal antibody. It's an anti-CD52 medication, and so it reduces circulating T and B cells as well as natural killer cells. It's approved for relapsing forms of MS versus Rebif. There's a 49% relative risk reduction in annualized relapse rate, 42% relative reduction in confirmed disability progression. And at year 6 from taking this drug, 77% of people on Lemtrada were stable or improved. So this is new language that you're going to see, right? We haven't talked about people being stable or improved on drugs. We've talked about people having slowed disability progression. And as our drugs become more modern and more effective, we're actually able to keep people stable or perhaps see them get a little bit better. There are serious side effects associated with Lemtrada because of the way it works. It can cause other autoimmune diseases. When your B cells start to come back, they come back, and instead of saying, that myelin looks good, they say, that thyroid looks good, or those kidneys look good. And so there are risks, low risks, but still risks of idiopathic thrombocytopenic purpura, kidney disease called Goodpasture disease, autoimmune thyroid disease, or just thyroid disease. Also certain types of cancer like cervical cancer, melanoma, immunosuppression, liver issues, and there have been some strokes identified with this medication as well. There are infusion reactions, and now we know how to pre-medicate prior to infusions to keep people comfortable and without infusion reaction. Prior to starting this medication, just like with Mavenclad, we do things like checking your hepatitis B, hepatitis C, HIV, and VZV status. We also check CBC, metabolic panel. You have a CBC metabolic panel and urinalysis with cell count done monthly for 5 years from your first infusion. We also have you do regular pap smears, perhaps more frequently than is recommended by your gynecologist prior to taking this medication if you're a woman, and you have to have regular skin checks. Finally, we have Ocrevus. This is a 300 milligram IV given once, 2 weeks later, another 300 milligrams, and then every 6 months you get a 600 milligram dose thereafter. This is a humanized antibody, humanized monoclonal antibody of very similar to a drug called rituximab or Rituxan, which many of you may have taken for MS. It's an anti-CD20 molecule, and it causes lysis of B cells. So the B cells basically break open and fall apart. This was studied also versus Rebif. There was a 46 to 47 relative reduction in annualized relapse rate versus active comparator. You can see here that it has some of the best MRI data, so 94 to 95% relative reduction in gadolinium enhancing lesions. Also a very good job at reduction in new or enlarging T2 lesions. And this drug is the only drug that's approved for primary progressive MS. It was studied differently in primary progressive MS. The primary outcomes for this were risk reduction in 12-week disability progression and risk reduction in 20% worsening of the time 25-foot walk. So in ocrelizumab compared to placebo, there was a 24% risk reduction in 12-week disability progression and a 25% risk reduction in worsening of time 25-foot walk. This drug is by and large well tolerated, but we do worry about infusion reactions. We pre-medicate for them and rarely see them. We also worry about infection because of prolonged suppression of your B cells. We check very similar lab work to the other IV therapies in Mavenclad prior to starting the drug. And while you're on the drug, it's not required that you check an anti-CD20 panel, but we do like to see that your B cells are staying low, and we may want to see what the rest of your lymphocytes are doing, particularly if you're having issues with infection. So people always ask about stem cell therapy. I could talk for 4 hours about stem cell therapy, so I'll make a couple of generalizations here. There were several good talks given at this year's Consortium of MS Centers annual conference, and I will say that as a generalization, the best outcomes are in highly inflammatory relapsing MS, and as a generalization, the best outcomes are seen with higher doses of chemotherapy used prior to bone marrow transplant or stem cell transplant, but there's also a higher risk with those higher levels of myeloablative therapies. So what's happening right now are clinical trials looking for that sweet spot, like how can we best give stem cell therapy without causing dangerous immunosuppression. I will also say, as a rule, we still recommend stem cell therapy at a very reputable center or in the auspice, under the auspice of a clinical trial setting. There has been finally, and for good reason, kickback against the for-profit stem cell clinics that charge anywhere from $10,000 to $25,000 to take out your stem cells from somewhere on your body and put them back in. This is not the type of stem cell therapy that is disease modifying or should be used to treat MS. In the pipeline, the closest drug coming out of the pipeline is ofatumumab. It's another monoclonal antibody that's an anti-CD20, and it's associated with a 50 to 58% reduction in annualized relapse rate versus teriflunomide or Aubagio. So again, when you see these lower numbers with some of these drugs with annualized relapse rate, you have to think, well, gosh, this is against an active comparator that we know to be a gold standard and effective treatment for MS. So let's move on to COVID-19. I think it's a really great place to start after a disease-modifying therapy talk. Some of the most frequent appointments that were made with me when COVID started were people wanting to sit down and really dive deep into their disease-modifying therapy and whether or not it was safe to continue because of the coronavirus. This is just a little cartoon about how to wear your masks. I had another one that I didn't think was appropriate to share, but it had something to do with underwear and men and where they might not wear their underwear right and comparing it to your nose hanging out of your mask, and you guys can use your imagination on that. But it's really important to wear your mask correctly. It's really important to protect yourself and others in public spaces and in close quarters, and just make sure that you're covering your nose and mouth. I will also say that if you have a pulmonary condition or you feel very short of breath or anxious underneath a mask, you might want to consider wearing a face shield. And hopefully, we don't know, but some say that wearing a face shield may also be protective. So I'd like to talk about a couple of studies. I will give it to the MS world of MS providers. They were on top of immediately starting to do research within the MS population to see what we could learn about the coronavirus in MS. An observational study from NYU MS Comprehensive Care Center took a look at over 300 patients who had COVID-19. And what they found was most people living with MS with COVID-19 did not require hospitalization, even though they were on disease-modifying therapies. Factors associated with critical illness were similar to the general at-risk population. So age, obesity, diabetes, cardiovascular disease, hypertension, chronic lung disease. Disease-modifying therapy use did not emerge as a predictor of poor COVID-19 outcome in this sample at NYU. There's also the COVI-MS study. So this is a platform whereby healthcare providers can submit cases of confirmed or suspected coronavirus. There are, at this point, as of last night, 692 confirmed MS cases that have been submitted to COVI-MS. Over 80% of those cases are people who are recovering. 5.8% of those cases have died, and over half of the people who died had comorbidities, the most common being cardiovascular disease, hypertension, and diabetes. Most people have relapsing MS and are ambulatory in the study. And of all of the cases, almost half of them had comorbidities like hypertension and obesity. So again, it's not MS that is increasing your risk for the coronavirus. It's other medical comorbidities. And these are very nicely outlined on the CDC website under special and at-risk populations. They have 2 pages dedicated just to this. So one other study on the left-hand side of this slide is an Italian study. And this Italian study also in a larger number of MS patients, about almost close to 800 patients with coronavirus. And what they found was that severe COVID-19 disease was associated with recent use of methylprednisolone and also anti-CD20 drugs like ocrelizumab and rituximab. So this data is different than what I presented on the last slide with NYU's data. So what sense can we make of this? People living with MS are encouraged. I'm going to kind of skip forward a slide. People living with MS are encouraged to continue their disease-modifying therapies. They're encouraged to have really honest and realistic conversations with their MS care providers about whether or not their disease-modifying therapy puts them at risk. As an MS care provider myself, I would look very carefully about switching a person to a new drug, and I would consider the stability of their MS versus their risk for coronavirus before I switch them to a therapy. By and large, if you talk to MS care providers like me, what you're going to hear is it's not the coronavirus that's going to get a healthy person living with MS, it's the MS, and we want to treat the MS. Now, that's a different story if you have medical comorbidities like obesity, diabetes, hypertension, cardiovascular disease, chronic lung disease, chronic kidney disease. Then the stew becomes a bit cloudier, a bit more complicated. I'm going to move back to this slide. So certain groups of people with MS may be at an increased risk of becoming severely ill with the coronavirus. And again, this isn't because of the mechanism of MS itself. Rather, it's because of your ability to fight off an infection because maybe you have swallowing issues or coughing issues or mobility issues, or you're already getting chronic infections. So those would be people with progressive MS, people with MS over the age of 60, people with higher levels of disability, the diseases that I already talked about, and also obesity, a BMI of 30 or higher. I did a presentation for MS Views and News. I think it was in March or April. It's called Holistic Wellness in Times of Need. I checked last night. You can find this on the MS Views YouTube channel. It speaks very specifically to things that you can do for your mind, for your body and for your soul to get through the COVID-19 pandemic, specifically about nutrition, exercise. There are resources for finding online and virtual exercise programs. There are lists of spices and certain types of foods that you can use to help your body stay healthy. There's also a meditation that you can read to help kind of protect yourself, protect your mind from what's going on. And there are suggestions for lowering anxiety, like limiting your news watching time, limiting your social media time, those sorts of things. So I'd encourage you to check that out for more information specific to how you can be healthy and well during the COVID-19 pandemic. That brings us to integrative medicine and MS. This is a chart that I've recently found that I've fallen in love with. It goes from the left to the right of paradigms of types of medicine. So conventional medicine tends to be disease-focused, treats symptoms using drugs, radiation, or surgery, and serves as the knowledge base for Western medicine. Alternative medicine is used in place of conventional medicine. It treats symptoms using natural products or natural methods, and not all treatments are scientifically validated. Complementary medicine is a modern approach that uses conventional and alternative medicines to diagnose and treat symptoms, and it's kind of a hybrid. Integrative medicine combines conventional and alternative medicines in a coordinated way, and the emphasis in integrative medicine is on evidence-based for the things that we do. And then functional medicine questions the foundation of conventional medicine, treats the patient, not the disease, and is scientifically based in systems biology. So it focuses on prevention instead of treatment. I practice integrative medicine. I was fellowship trained at the University of Arizona, and I bring that to MS in several ways. I treat the whole person. I include all aspects of that person's lifestyle. There's a strong emphasis on the relationship between myself and the person and their support system. And I try to really facilitate healing, even if a cure isn't possible. There's a lot of focus on physical, emotional, psychological, and spiritual aspects of you as a person living with a medical condition. And it takes a lot of time. So a typical visit with me in my integrative medicine practice, a follow-up maybe 60 to 90 minutes versus 25 minutes in a conventional medical setting. Integrative medicine in MS means that I still prescribe conventional medical treatments, but I also may recommend complementary and alternative treatments for which there's evidence for benefit rather than harm. It is careful examination of the available evidence for these types of therapies applied so that you get the best care. It's not giving you 1 million supplements instead of your 1 million pills. It's not recommending to you fad diets with elimination of healthy food groups, and it's not saying that it's okay to do something because one guy on YouTube said it was. So I think that's really important. We spend a lot of time in integrative medicine making sure that there's evidence that what we do is beneficial and not harmful for you. An integrative medicine treatment plan in MS includes a comprehensive medical history, and you can see there what that entails. Things that are new to you might be medication exposure over the course of your life, like antibiotics, steroids, NSAIDs, proton pump inhibitors, toxin exposure, including environmental toxins, things that are in the air, where you grew up, things that you put on your body, and supplement and botanical use. You might not be used to your healthcare provider asking you about your spirituality or what you do for self-care. And so these are things that are different than in a conventional medical workup. Development of a plan in integrative medicine includes medication adjustment and perhaps the recommendation of supplements and botanicals. It may include labs that you're not used to having typically when you see your regular healthcare provider, and also referrals to other appropriate providers for things like mind-body work, spiritual work, manual therapies like acupuncture, massage, nutritional therapies that are really outside the scope of my practice. For example, I am not trained or licensed to do acupuncture, so I refer people to an acupuncturist. And also communication and collaboration with your other healthcare providers. So I'm going to give you some brief bullet points here, and I think I'm going to end up being on time, which is amazing. I look forward to your questions, which are almost, perhaps more important than just me regurgitating information to you. So nutrition, basic bullet points. Eat food, not too much, mostly plants. I really don't need to say anything else, but I'll tell you a few things. Nutrition is important because of cardiometabolic risk and comorbidities in MS. Nutrition is important because it affects obesity, it affects pain, it affects bladder and bowel function, depression and fatigue. Poor nutrition can lead to constipation and inflammation. And the microbiome, which is the bacteria that live in your gut, affect your immune system, and your immune system in your gut affects the gut-brain connection. So there is importance of nutrition in MS. These are my rules to live by. I'm not going to talk today about each specific, quote, diet that you may have heard of in MS. I'm just going to give you some basic things to think about. Reduce processed foods. If it has more than 5 ingredients or you can't pronounce them, don't buy it. Eliminate sugar-sweetened beverages and reduce your use of artificially sweetened beverages because the artificial sweeteners can actually irritate your bladder. Eat a colorful plant-based diet. If you choose to eat meat, let meat be a condiment, not the center of your plate. Buy according to the Clean 15 and Dirty Dozen, and those are lists of, so the Dirty Dozen are the fruits and vegetables that you should be buying organic, no matter what. The Clean 15 are lists of fruits and vegetables that you don't need to buy organic. These are just common vegetables. And you can find these on ewg.org, Clean 15 and Dirty Dozen. They change every year. Make thoughtful seafood and animal protein choices. So you want to make sure that your seafood is sustainable, that for the most part it's wild caught and not farmed. Animal protein should be grass-fed, grass-finished, hormone and antibiotic free. And you may want to consider the humanity of how those animals are cared for. Eat your omega-3s. Eat your nutrients. Eat your prebiotics. Eat your probiotics. You don't necessarily need to take these in pills. And also, the World Health Organization a couple of years ago named processed meats, particularly beef and pork products that are salted, cured, fermented, smoked, etc. This includes lunch meats. As class 1 carcinogens. So don't eat those. Let's talk about movement. I've started talking about movement instead of exercise because I feel like when I say the word exercise and I look out into an audience, I see people look tired or discouraged. And that's probably because there's an exercise hang-up. And by that, I mean you might not be able to do what you used to do. And so you choose to just not exercise. So I'd like you to think about whether or not you're willing to change your idea of exercise as moving your body instead of, I can't go to the gym anymore, I can't run like I used to, I can't dance like I used to. What can you do to move your body that you enjoy? Exercise is associated with decreased weakness and fatigue, better mood, better bowel and bladder function. Depending on the exercise, there's also an association between improvement in spasticity and pain. And the basic necessity is to play and move your body every day. There are so many things to choose from. It's important to exercise during your best time of day, to conserve energy by breaking up your exercise. So maybe you do 10 minutes in the morning, 10 minutes in the afternoon. Consider medication side effects. For example, if you take a muscle relaxer that makes you sleepy, don't plan to exercise 45 minutes after you take your muscle relaxer because you might just kind of decide to lay down and fall asleep instead of stretching. Ask a physical therapist or an exercise specialist for an evaluation. Use cooling equipment, stay well hydrated, and get your family involved. You might say, well, what am I supposed to do now? It's COVID-19. I can't go anywhere. I can't do anything. There are so many resources online for people living with MS. There's My MS Gym, there's MS Workouts, there's Dr. Gretchen Hawley, who many of you have probably heard spoke for MS Views. There's OMS Yoga, which is my yoga nonprofit. We currently offer 4 free yoga classes virtually every week. So there are plenty of things to do from your home. Sleep. Oh, sleep. So fatigue, probably the most common symptom of people living with MS, the one that's the hardest to beat. But MS may not be the sole cause of your fatigue. So sleep disorders like sleep apnea and restless leg can be common in MS, and it's important to also consider your medications and whether or not they affect sleep initiation and sleep maintenance. We all know that bowel, particularly bladder function, can also keep you up at night. So there are lots of things that can affect your sleep. We can't always assume it's MS. We may ask you to have a sleep study. We may talk to you about anxiety or depression and how that is affecting your sleep, and even how your diet is affecting your sleep. Maintain a regular sleep-wake schedule to practice good sleep hygiene. Develop a relaxing evening ritual, like turn off the news. Let me just say it again. Turn off the news. Don't look at your phone, surf on the internet, surf on social media. If you use your phone or a device to read, use a blue light filter or blue light glasses. Avoid caffeine, sugary foods, and alcohol before bed. Keep your bedroom cool. Don't watch the clock. And instead of practicing going to sleep, practice letting go of waking. And that kind of invokes a relaxing response. You're going to let go, not go. Reserve the bedroom for sleeping and sex. That's hard for a lot of people. People do everything in the bedroom. Find a different place to do that, and let the bedroom be your sanctuary for rest. Mindfulness. What is mindfulness? Well, it's not the girl on the left in this slide. It's the girl on the right. The girl on the right is 100% focused on what she's doing in the moment. The girl on the left is 0% focused on what she's doing in the moment and thinking about all the other things that she had to do. Why is mind-body medicine important in MS? Well, stress releases chemicals that are inflammatory and that are involved in the immune response. We have studies in MS that show significant stressors in MS may be associated with relapse and MRI activity. And it's really easy to go from that peak performance, that healthy and focused, to fatigued and sick. And I saw this happening even in myself during the COVID-19 pandemic. I was motivated to change the way that I was doing things, and I was saying yes to everything to help out with the virtual world, and then suddenly I was exhausted, even though I was doing something that I loved. So it's important to give your mind some time to chill out. Stress management techniques include taking care of your body with a healthy diet and exercise, getting adequate sleep, and then following a routine for mental health and spirituality. That may be going to see a counselor, it may be journaling, it may be meditation, it may be finding a regular spiritual practice, it may be just being involved in your community and seeing your friends, your family, doing church or synagogue on Zoom, joining support groups on Zoom, using social media, things like that. I'm going to talk briefly about supplements. I believe, as many do, that our bodies were meant to heal with food. One example I can give you is that studies about fish oil, not just in MS, but also in cardiovascular disease, have revealed that we do much better when we eat fish rather than take our fish oil in capsules. People ask a lot about superfoods. Don't eat blackberries every day. Don't eat acai every day. Switch them around. Incorporate new ones. Try out new things. Try different colors and textures of foods so that your body's always getting different nutrients. Think of kind of in the old times when we rotated crops. We weren't eating sweet potatoes all year long. We weren't eating, luscious summer tomatoes all year long. We couldn't eat strawberries all year long. So rotate your crops, so to speak. Take time out to think about trying varieties of food. And when you think similarly about taking supplements, think of eating mass quantities of certain foods in isolation. And that ultimately may not be good for you. It can lead to toxicity, it can cause drug interactions, or it could be a waste of the money you're spending on food. So how do you know if a supplement or a modality in integrative medicine is safe or worth trying? This is my little algorithm. Is there evidence that it's helpful for an MS symptom? If yes, does that evidence outweigh the risks, including the financial risks? And if yes, then it's safe to try for a couple of months. If there's not evidence, then, and you want to try it anyway, is it harmful or costly? If it's not harmful or costly and there's not evidence, well, then you may want to try it for a couple of months. However, if it is harmful or is costly, then you shouldn't try it. So if that one doesn't work, maybe a good integrative practitioner can recommend an alternative supplement to try. And I think it's important to always have realistic expectations of what you're trying. There's so much information available on the internet. There are so many supplement companies, multi-level marketing companies that are telling you that these things can do incredible things and change your life, and many of them are very costly. I would say that if you can't find a good scientific study very easily on a website, move on. My last slide, I think this is probably the most important slide of the entire presentation right now. Is we can't be together, we can still create really great memories by changing the way we've had to live our lives in the past 6 months. So especially right now, live for the moments that you can't put into words. And with that, I thank you, and I think we'll move on to questions.
Thank you very much. Thank you very much. Excuse me 1 second. Hi. Hey, everybody. Thank you.
Hi.
Thank you, Megan, for doing this. That was fabulous.
Should I stay here?
Yes,
Okay.
definitely stay there. In fact, I'd like to be in the front of the room too, but with being on the phone, taking questions from Roanoke, and having to read questions, and having to hold the microphone, I just haven't learned how to have 3 hands yet.
I mean, we
Okay.
haven't learned how to grow them.
No, we have not. So what we're going to do is, I think that we're going to take one question virtually first, because Roanoke needed to do something real quick. So we're going to take one question virtually first, and then I will get back to them as well. So can you tell us now? Some of these questions are going to be back and forth with where you were in your conversation, but
Okay.
that's only because they asked the questions in that order, and I can't ask them any other way.
Okay.
All right. So what do you think about intermittent fasting for multiple sclerosis?
I think that's a great question. So what do I think about intermittent fasting for multiple sclerosis? So I think intermittent fasting is something that's reasonable to try if you don't have a medical condition that precludes you from doing it, for example, diabetes. Intermittent fasting in the scientific literature specifically has the best data for secondary prevention of certain types of cancer, and the sweet spot is 13 hours. When you're talking about intermittent fasting in the popular literature, people are recommending anywhere between a 14 and 16-hour intermittent fast, and the whole purpose of this is to induce ketosis. There's a thought that ketosis helps to strengthen your mitochondria, and that in turn can lead to better neurological health. I tend to stick to recommending a 13-hour fast based on the scientific literature. I also assess a person for any history of eating disorder, because intermittent fasting, particularly long fasts, can invoke old eating disordered habits to come to light. So it's important to take on something like this under the care of either a healthcare provider that's familiar with it, or a licensed dietitian. I'll also say that in one of the oldest forms of medicine, which is Ayurveda, also another oldest form of medicine, traditional Chinese medicine, it's recommended that you eat dinner early, like around 5 or 6 o'clock, and that you not eat again until 12 or 13 hours later. So it's not new medicine. It comes from old data that our bodies need to rest at night. We tend to be too busy, stay up too late, eat too late, get up too early, not sleep enough. And so we're just trying to go back to old habits, I believe, with a reasonable intermittent fast.
All right, next question before we get to Roanoke. Next question before we get to Roanoke. I forgot which hand with the microphone was in. Exactly.
I don't know where to look.
All right, so somebody online just asked, if I'm on Copaxone daily for MS, does this provide any protection against coronavirus?
That's a question. Okay. No, not that we know of. The only disease-modifying therapies at this point that we know may provide some protection against coronavirus or interferons because by nature they're antiviral. There's also some suggestion based on one study that fingolimod may protect against the coronavirus, but we just don't have enough data, enough people with MS on those drugs with COVID-19 to know whether or not that's the case.
Okay, perfect. And from Roanoke, we have our first question. Yay, you guys
Roanoke.
there, right? All right, so they want to know if there's MS relapse, can you explain what the 2 different or 3 different therapies that they might be for relapse other than typical steroids?
Oh, certainly. So ACTH, adrenocorticotropin releasing hormone, or Acthar gel, is an injection that's given sub-Q or in the muscle. It's typically given 5 days in a row. It may be repeated depending on your response to it. I'm just going back to that slide. Plasma exchange is a pretty significant medical procedure that requires placement of a central line, usually in the neck. Most of the time you're in the hospital receiving that. IVIG is even less frequently used. It's also an IV therapy that can be given on an outpatient basis, usually for 5 days in a row.
All right, one moment. All
Yeah.
right. So while we're taking that one, let me ask you another one. What can we eat to reduce our MS symptoms?
Well, you can follow these rules. So I'll move to that slide. Let's go forward here. So basic rules of nutrition: eat food, not too much, mostly plants. Eat a diet that's mostly plants of various colors and textures. Don't overeat. Don't eat processed foods. Don't eat sugar-sweetened beverages. Eat lots of omega-3s in your diet. Eat good, healthy fats like fishes that are high in omega-3s. I call them the smash fishes. So salmon, mackerel, anchovies, sardines, and herring. Eat nuts that are high in omega-3s and vary your nuts so that you can get different nutrients, different minerals, walnuts, hazelnuts, almonds, healthy fats, extra virgin olive oil. Making changes like this in your diet can make significant changes in your MS symptoms depending on how unhealthy your diet is.
All right, another question from Roanoke is, do you know what NIA is?
NIA?
As in a integrative therapy using exercise?
Oh, yes. Is it NIA or NEO? They're probably not going to be able to tell me.
NIA, I think they just had
so
somebody
it's
today.
like a combination of yoga, Pilates, dance, martial arts. I have a very good friend who lives with MS in Maryland who introduced me to NIA. I've never done it myself, but I have another friend from Hawaii who does it, and they love it. I think it is a great form of exercise for people living with MS who are able to, it's a good cardiovascular exercise, would help with balance and strengthening. I don't know of any studies, but I think it's a good form of exercise.
Okay, next question from Roanoke. Do they want to know that if they're to be using Supposia, is there going to be any problem with that? And if they get a live vaccine, what would happen with the use?
Yeah, so with most of our newer disease-modifying therapies, I'm going to go back to our oral slide here. It is recommended that you get live vaccines at least 4 weeks before you start the disease-modifying therapy, particularly with the S1P receptor modulators, with dimethyl fumarate, with teriflunomide, and with Mavenclad, also with our IV therapies. With Ocrevus, because it's a therapy that happens every 6 months, there's kind of a sweet spot if you need a vaccine, and it's about 2 weeks before your next infusion, 2 to 4 weeks before your next infusion.
All right. If a person is planning to go to Europe when the world opens up again, what can they do to help themselves with fatigue to prepare for the trip and during the trip?
I think that I would really use the time in the weeks prior to healthy up your lifestyle. So if you recognize that your diet isn't up to par with some of these easy things, easy changes that I recommend doing, I would go ahead and make some of those changes. I would get extra rest. I would learn how to drink an adequate amount of water. I would gradually work on movement, balance, and from the standpoint of fatigue, I think you also have to consider cognitive fatigue. So I would really take the time to plan out your trip. As far as places that you might want to go, how your transportation, how you're going to access your transportation and what kind you're going to use, where you're going to take your meals, where you can get fluid and snacks, that sort of thing. Really plan out those events so that you can take away some of the cognitive fatigue that may come from traveling.
Okay, next question.
Also take melatonin with you so that you can sleep when you get there.
Sorry for cutting you off. So the next one is, what recommendations do you have for people having to live with COVID now insofar as social distancing and face mask wearing and so on?
Yeah, so I believe in social distancing and face mask wearing. It's pretty much as simple as that. If you are in a public place, an enclosed public space, you should wear a face mask. If you are, the CDC lists has a list of things to avoid, like still recommending avoiding large social gatherings of more than 10 people in certain places. We live in Florida. Florida is currently a COVID mess. The number of cases the past 3 days have been on the decline. However, the number of hospitalizations and deaths are up just because of the natural history of things. But I think our state became a mess because there was kind of a free-for-all of people wanting to get back out and not thinking about the greater good. So I think it's important to continue wearing masks and physically distancing, particularly if you're in one of those high-risk groups of individuals with or without MS.
The next question is, for when vaccines do come about, do you recommend that people with MS can take them? And I'm going to go a little bit further with that, because a lot of people do ask if they should be waiting for a dead vaccine. And what might be the answer for that?
Oh, my goodness. So the last time I checked, there were over 150 types of vaccine, or not types, but companies trying to make vaccines for COVID-19. All of these vaccines, to my knowledge, are live. This is going to create an interesting situation for people living with MS. And to be completely honest with you, we won't have a vaccine probably until the end of the year. And at that point, we're going to have so much more data than we have now that I really don't think I can answer the question with good science. A live vaccine and your risk for COVID, you have to weigh your risk for COVID with the risk of coming off certain disease-modifying therapies to take a live vaccine. You have to look at the efficacy of the vaccine, which we truly don't know the efficacy of the vaccines right now, because the studies at this point are like 48 people was the one published in the New England Journal, with the next batch to be 30,000. So that's the kind of data that we need to watch for. And then also, considering potential adverse events associated with RNA vaccines, because in the past they have occurred. So I think we're just going to have to wait until these larger studies are published before I would feel comfortable, lining up recommendations.
Thank you for that. And getting away from COVID for a moment, though we do have a lot of questions coming in online about COVID, but getting away for a minute, a person wants to know in Roanoke if the keto diet, how is that effective or not for people with MS?
Okay, so the keto diet. So the keto diet is a high-fat diet, very low carbohydrate, high fat, low carbohydrate diet that induces ketosis, or the process of the production of ketones in your body. It's thought that ketones cross the blood-brain barrier easier than glucose does and provide your brain with more energy. It's also thought that ketosis stresses your mitochondria just a little bit, so they learn to perform better. Some of you may be familiar with the Walls protocol. The Walls protocol actually has 3 different levels, and as you go from level 1 to level 2 and level 2 to level 3, you start instituting parameters that get you closer to ketosis. There has been one small study done in multiple sclerosis looking at specifically not the Walls protocol, which we call a modified paleo diet, but a ketogenic diet, and what they saw was an improvement in insulin resistance or blood sugar, and an improvement in mood and fatigue. So I would be very careful about doing the keto diet correctly. In fact, I would recommend that you discuss it with a licensed dietitian. If you go just from information on the internet, it gives you license to eat a really high-fat diet with foods that can increase your cardiovascular risk profile. What I've seen in my own practice is that if you don't do this correctly, your cholesterol gets really high, and that in and of itself could be dangerous.
All right, great. So as we're going forward here, I just want to let the people in Roanoke know that if you feel uncomfortable about being in the room that you're in and you wish to leave, you will be able to see the rest of this program online in a few days, and feel comfortable with leaving the room now, so that way you're not that close, I hear, with others any longer. Though I am very happy, and I'm glad, I do want to say, for those that are in Roanoke, I found out that the tables are greater than 15 feet apart, so that's fantastic, and they had a nice little crowd there this evening, so I want to thank them all for coming tonight. All right, next, that's it with tell them thank you, please, and online. And all right, so now we're going to get back into the questions that we have online, and we do have about 40 questions. All right.
My goodness.
Right, exactly. So for those that are in Roanoke that do want to stick around and listen to this, that's great. But if you do want to leave the room, we understand that as well. And for everybody else, thank you for remaining online with us. So a person in the state of Virginia who was not at this program says that she's got a child that will be a senior in school this year. Where did the question go? I'm sorry, I lost it really briefly for a second. I think she's in Virginia. She may not be.
I'll just say this while you're looking for it. In regards to the vaccine, I don't want to come across as anti-vaccine. I just don't quite know what to recommend until I see the data.
That is quite correct. That is quite correct. All right, so the person says, I have a child that will be a senior in high school. Our schools will not be requiring face masks inside the classrooms. Would you recommend your patient's school to do this online? Would you recommend that your patient child goes to school or learns from home online?
So that's such an individual question. It would have to do with your child's psychological and educational needs. It would have to do, it would take into account the COVID situation in your community, would take into account your risk factors for COVID-19, including the disease-modifying therapy that you take. And, ultimately, I think that question is best answered with your physician and as a family.
Great, thank you for that. Next one is, how do you enroll in free online yoga class?
So that's super easy. So you go to yoga.org. That's omsyoga.org. On the far right of the website, there's a tab that says live stream. Click on that, and there are directions. The directions give you a link to a website called Vigaro. On Vigaro, you search for OMS Yoga. Each week, classes are listed by week, so you can register for one at a time or a million at a time. The schedule is up through January. You'll complete a waiver online, and then you'll get a link to join the Zoom class.
Okay, thank you.
Sure.
Even though the function of DMTs is to help stop the progress of MS and not to address the associated symptoms, why is it that one very significant symptom totally stopped when starting on my DMT?
Well, it's possible that your disease-modifying therapy drove down inflammation. I don't know what symptom you're referring to, so it's kind of hard for me to theorize about that. But sometimes when you start on a disease-modifying therapy and the inflammatory components of the disease calm down, you do have improvement in symptoms. Some disease-modifying therapies post-marketing have looked at improvements in fatigue, and they've found those. Again, some improvements in mobility with newer disease-modifying therapies. So I think the answer is just that the disease-modifying therapies are improving the mechanisms of your body, and so it's working with you instead of against you.
Thank you. What MS therapies are there for those with progressive MS?
So the only approved disease-modifying therapy for progressive MS is ocrelizumab or Ocrevus, which is an IV infusion. After the starting dose, it's given every 6 months. Get back to that slide here. There are, a couple handfuls of other types of drugs being studied for progressive forms of MS, not just primary progressive MS. There are, if I close my eyes and remember the article I just read, there are probably 25 different drugs that are being studied for neuro protection and neuro regeneration. These studies are all in phase 1. Most are in phase 1, some are in phase 2. So we have a few years before more things happen in progressive MS.
Okay, here comes another great question for you. I suffer from chronic issues with sciatic pain and have issues with gait stability. Are there any good MS-centric online yoga classes with not so skinny instructors out there?
I am sorry that a skinny yoga instructor is offensive. I'm not aware of
It's crazy.
Where you can find. That really kind of leaves me speechless.
So why don't we ask this correctly? What exercises can they do using yoga for sciatic pain?
Okay, so I would recommend checking out either OMS Yoga or Yoga Moves MS. Yoga Moves MS is another MS-specific yoga program. And I'd also recommend looking in your community for a certified yoga therapist. So a yoga therapist is actually trained a little bit more medically than a yoga teacher who really isn't trained, in medical yoga, so to speak. There are many yoga poses that could be helpful for sciatica, and then some of the things that you think may be helpful could be harmful. I know it's difficult because of COVID right now that people are looking for online resources, but if you have sciatic pain, I would just recommend checking in with a physical therapist and getting on a good stretching program that would help you.
Great, thank you. Can you tell us about chair yoga?
Sure. So chair yoga is great for people living with MS because it takes the fear of falling out of the yoga program. It can still help with balance because there's a strong focus on your core. It can still help with mobility, again, because there's a strong focus on your core. And as a practitioner of yoga, when I practice chair yoga, I actually get a lot more opening and mobility in my middle and upper spine than I'm able to when I'm standing. So I think chair yoga is a great way to introduce yoga into your exercise practice. OMS Yoga has a chair yoga class offered virtually on Sunday afternoons, and Yoga Moves MS has chair yoga classes throughout the week as well that are offered virtually.
Great, thank you. Can you tell us your opinion, please, on CBD and medical marijuana for MS?
Sure. Do I have another hour?
Yes.
I don't. I'm a tired 3-year-old. So medical marijuana, medical cannabis in MS has been studied specifically for spasticity, neuropathic pain, and bladder spasticity. Oral cannabis extracts have shown benefits in those 3 things. So bladder spasticity or overactive bladder, spasticity that is no longer responsive to medications, and also neuropathic pain. We tend to recommend against smoking medical cannabis because this has been associated with cognitive impairment in MS, both with short-term and long-term use. CBD is a different animal than medical cannabis. CBD lacks THC. THC is the component that tends to be psychoactive in medical marijuana. CBD products can be, to be beneficial, you want to be sure that you find a CBD product that is as standardized as possible in quality and consistency so that every drop you get out of that bottle is the same, and that's hard to do. I'm careful about recommending CBD because I don't always know where it's coming from for people. I mean, you can buy it at the gas station these days down here. I think that you really do pay for what you get. I think of CBD as a homeostatic therapy. So I think that when it gets into the brain and the brain uses the endocannabinoid system, it kind of puts out fires. And CBD, unlike medical marijuana, may not give you a quick relief of symptom. If it does, it might be a placebo effect, and okay, but it might require taking it for, say, a week or a couple of weeks before it really starts to work in the body to drive down any process that's causing excitation, like pain or anxiety or insomnia. I think that, didn't you guys just do a program with Ben Thrower?
Yes.
That's specifically about CBD?
No, he did that. He did his own event. I just helped promote it. That's all.
Okay, all right. So there are several MS physicians who are much more knowledgeable about CBD than I am, and I will fully admit that. Dr. Ben Thrower is one of them, and he recently did a program specifically about CBD and medical cannabis that would be worthwhile searching for and listening to. There are risks involved with medical cannabis, and those include drug interactions. They include psychotropic effects or psychogenic effects. They include the safety of the marijuana itself. And there are also medical conditions that can happen with medical cannabis that can be very serious. So I think it's definitely a decision to chat with your healthcare provider about.
Okay, thank you. Going on to acupuncture, can you tell us how does acupuncture assist with MS symptoms?
Sure. So there's not tons of literature regarding acupuncture and MS. What there is suggests that it may be helpful for spasticity and pain. Personally, and with my patients, I tend to recommend acupuncture for those things, but also for anxiety and perimenopausal or menopausal symptoms. So I do think that acupuncture can be beneficial for symptoms in multiple sclerosis.
Okay, next we have, what are your thoughts? Well, you already actually told me that. Tell us more about vitamin D's effect on MS.
Okay, so vitamin D's effect on MS is probably a lot more vast than we initially thought it was. Data that comes out of the military told us that people with low levels of vitamin D have a higher risk of MS, and perhaps low levels of vitamin D in MS are associated with higher relapse rate, higher burden of MRI disease and disability. Some of the more modern trials, there are some that argue that. But I think as a rule, vitamin D is very important in MS. Your MS care provider or your primary care provider should be checking it at least once a year. In multiple sclerosis, we typically like the vitamin D 25-OH level to be around 50 if you don't have renal or kidney or liver disease. And D3, vitamin D3, is the most bioavailable form of vitamin D. So before you start taking it, I would get your level checked so that you know how much to take.
Fabulous. And just so to let you know before we get on to the next question, Megan was very well received in Roanoke, and many said they loved listening to her easy-to-listen approach, and they loved you.
Well, thanks, because I sure don't love all these charts I made.
They're still listening. They're still listening, by the way. So, yeah.
Thank you, guys.
That's great. All right, so some of them will be able to hear you again tomorrow, and that will be fabulous, okay? All right, so going on to the next one. You might have answered some of this while you were talking, but maybe not all, so let's, do it again. Person writes, I'm specifically interested in therapies that might, number one, improve balance, 2, diminish nerve pain, or divert the mind's awareness of pain?
Oh, beautiful. Yeah, that's a great question. So specifically interested in therapies that might improve nerve pain or divert the mind away from pain. So these are mind-body therapies. There are so many, it's almost impossible to find one that doesn't work for you. When it comes to pain, if a person is new at mind-body therapy, I tend to recommend guided imagery. Guided imagery is sort of like guided meditation. However, unlike meditation, if you fall asleep during guided imagery, the benefits to your body are still the same. So distraction techniques like that, like meditation, can be helpful for pain. The best resource I've found for guided imagery is Kaiser Permanente. They're the big healthcare system on the West Coast. Kaiser. If you Google Kaiser podcasts, one of the first links that will come up, I think it's something like Podcasts for Healthy Living, and it's a long list of guided imagery podcasts for various things like pain, headache, anxiety, sleep, cancer, forgiveness, all kinds of things. So I would encourage you to start there. And when you have pain, just engage with that practice of guided imagery.
Okay, fabulous. Thank you. We have just 10 questions remaining, okay? Just 10 for the moment, unless we get more from... Actually, we just got one. Let me read one of the others first before I try to figure out that one there, though. And that is, what kind of health nutrition can be provided to best benefit the brain?
So I'm going to go right back to this side. Eat food, not too much, mostly plants.
What? Sorry.
Eat food, not
okay,
too much,
it.
mostly plants.
Got
High
it,
in omega-3s. This slide right up here.
I got involved with reading the next question. So back to Roanoke, they say that you've got a newly diagnosed person hanging on to every word. what's the best advice you can give for a newly diagnosed person?
Oh my gosh. Connect with other people living with MS. If you have not seen an MS specialist, see an MS specialist. At a nearby comprehensive MS center or Partners in Care center, and you can find one of those by looking on the National MS Society's website. Try to use reputable sources of information. I recommend the MS Views and News website. I recommend the National MS Society, MS Association of America, and MS Foundation to get really great information. And if they're in Roanoke, is that right?
Yes.
Yeah, so hook up with other people living with MS. Don't be afraid to make connections, learn from them, use them as resources, and just know that this living with MS is really a hopeful place to be because of all the disease-modifying therapies that we have and everything we know about how to manage symptoms and connect, don't disconnect.
Great. I totally agree with the part where you told people to check with the MS Views and News website. Thank you for that.
Yeah, you're welcome.
All right. And for the person that is in Roanoke, that alliance that you're there with tonight, the Multiple Sclerosis Alliance of Virginia, is a fantastic organization. And that's why we decided to partner with them tonight, to do this program. And yeah, we are doing it from far away, but it is working out perfectly. And, we do a lot with them. And I'm glad that that organization is there for the people in Roanoke, not just Roanoke, but all of Virginia. And because they do a fabulous job. And they're strictly 100% volunteer-based, which makes it even better. Thank you, guys. All right. Next question. I've been told by neurologists, not me, but the person, I've been told by neurologists that I am now SPMS after a certain age. And he or she writes, I am 66. The therapies won't work anyway. What do you feel about this? That's what her neurologist or his neurologists are saying, that the therapies won't work because he or she is 66. So what do you feel about this? He or she did Avonex for 7 years, Rebif for 3, and Copaxone for another 7, and that person is now in a wheelchair.
So, it's really a loaded question. I have a problem taking people off disease-modifying therapies just based on their age alone. If they've had progression, mobility progression, cognitive disability progression, and their MRI has been quiet and they haven't had relapses, certainly natural history would tell us that as you get older living with MS, immunosenescence occurs and your body's not as inflammatory. But how am I to know that without taking you off your disease-modifying therapy that may be keeping your relapses and your MRI inflammation at bay? There are a couple of studies that are being in process right now. One of those is Disco MS, and it's looking at people over 55, taking them off their disease-modifying therapies and see what happens within that 2 years. That study has not been completed yet. As far as a person at 66 who's in a wheelchair, if you're not currently on disease-modifying therapy and you haven't had relapses and you haven't had MRI change, then I would probably work very hard on your symptoms and lifestyle. However, if you are having relapses or MRI change, then I would consider disease-modifying therapies that have some data in secondary progressive active MS like Mayzent or Siponimod.
Great, thank you. Well, can you tell us the proper level of vitamin D that should be being used?
So your level should be around 50. Vitamin D 25-OH should be around 50. Have your level checked before you start taking it.
Maria from Miami wants me to tell you that you are extraordinary.
Thank you, Maria.
All right, next one. Best non-prescription therapies for relapse-remitting MS that concerning diet and exercise.
Best non-prescription. So I would say follow a whole food plant-based diet like I've mentioned many times, and exercise enough So we recommend 150 minutes per week. That translates to about 22 minutes per day. Vary your movement, do things that you enjoy, and keep up the hard work.
Great. Thank you. I was told there was a new drug out for MS. Can you tell us what that is?
Yeah, so the newest drug to be approved is Zeposia or ozanimod. It's an S1P receptor modulator. It is here at the bottom of this slide. It's approved for relapsing forms of MS. It was studied versus Avonex. It has a good safety profile, doesn't require an FDO, and there's also some good data about gray matter atrophy being better with Zeposia than with Avonex.
Okay, thank you for that. Next person writes, I am an SP-MSer for 16 plus years. What do you suggest to a patient if none of the prescribed medications from start till now have had no positive impact on controlling or reducing spasms, but just has been an expense and difficulty taking the meds on time?
I would say consider a baclofen pump trial if you have not already done so. You may also consider a trial of acupuncture. You may consider different types of exercise or physical therapy to try to help with spasticity. You may consider medical cannabis.
Can you go closer to the mic?
Oh, I'm sorry.
Oh.
Yes, so you may consider baclofen pump trial if you haven't thought about that. You may consider acupuncture, different types of physical therapy and exercise therapy. You may consider medical cannabis, diet changes like decreasing caffeine and alcohol use, things like that.
Thank you. All right, rolling along here. Let's see, what's next? Can DMTs change your DNA?
Not that I know of.
That was a quickie. All right. Is there a recommended diet? I think we might have asked this before, but is there one specific recommended diet for MS?
There is not one specific diet recommended for MS.
Can you tell me what diets there have been or that are discussed for MS?
Yeah, so you can look up the WAHLS protocol, WAHL''S, the Swank diet, the Gold Coast cure, the McDougall diet. I tend to recommend Dr. Andrew Weil's anti-inflammatory diet. It's on drandrewweil.com. He's my teacher.
Great.
Yeah, lots of things to choose from.
Perfect. Thank you.
All healthy. I'm sorry, they're all healthy.
That's right. Which essential oils work best for MS, especially for heat and balance issues?
Oh, goodness. Well, for heat issues, I would think that, cooling, when you come into a cool atmosphere, that cooling and calming essential oils would help you cool down, maybe diffusing peppermint or things like lavender, ylang-ylang, neroli, orange, grapefruit. Those things are good for driving down the sympathetic nervous system. For balance issues, I'm not sure specifically what essential oil would be good for that. I know that many people with MS use frankincense as an essential oil. I don't recommend ingesting essential oils, but I think diffusing them or using them on the skin is really nice with a good carrier oil.
Great, thank you. Are there any DMTs that are adversely affected by the use of complementary therapies?
Yeah. So the answer is truly, we don't know. And many complementary, well, I'll say this, not by complementary manual therapies, but by supplements, herbs, and botanicals that affect the immune system. We do have data from oncology or from cancer, from in vitro, like in the petri dish and animal settings, that there are very potent herbs and botanicals that can affect or counteract or cause an enhanced effect of the way that immune modulator or immune suppressive therapy works. And that is why it's difficult to say without reservation that many herbs and botanicals that might help people with MS are safe to take. They truly haven't been studied with disease-modifying therapies. And if they have been studied in MS, they're very small studies. So I have really honest risk-benefit recommendations with patients when I recommend herbs and botanicals. Sometimes I'll use them for short periods, but I will not use them if they have the potential to either cause an enhanced effect or an opposing effect of a disease-modifying therapy.
Okay, thank you. Next one is, what are the most popular complementary therapies for multiple sclerosis?
In general, I think it's probably supplements, yoga, massage are probably, the ones that are used the most.
Okay. Next one is, can you tell us about, one moment. Can you tell us about, yes, is it safe to maintain a gut microbiome during microbiome diet long term?
So I guess the way that I would answer that is if you're eating foods that are prebiotic foods, high in fiber, that's considered prebiotics, like legumes, beans, peas, oats, asparagus, onions, garlic, and then probiotic foods like fermented dairy, certain fermented foods. If you're incorporating those into your diet as a part of a healthy and well-balanced diet, there's no harm in that. If you're restricting your diet to only those foods, then you're at risk for nutritional deficiencies and excesses.
Great, thank you. And what can you tell us about leaky gut?
So leaky gut is I would say in functional medicine and integrative medicine, it's something that we talk about a lot. In conventional medicine, it's kind of an eye roller. But basically, and by that I mean literally like people rolling their eyes, like it doesn't exist. But what we believe is that if the microbiome is not healthy, then it allows for a dysfunctional immune system, which causes literally an increase in the tight junctions of the cells that are in your intestines, and it allows components of the immune system to get into other parts of the body via the bloodstream or lymphatic system, and thereby cause inflammation and potentially autoimmune disease. Leaky gut, symptoms can be associated with irritable bowel syndrome, indigestion, and really unhealthy diets. So diets that are high in processed foods, refined sugars, lots of stress, poor sleep, certain long-term use of certain medications that affect your body's ability to absorb micronutrients and vitamins. So I believe that leaky gut is a real thing. I just said it on television. And I think that that if you change your diet, just like if you change your mind, you can change your life and your gut.
Perfect. Thank you very much. Now, normally, I would come over and I would shake your hand and do so many other things, but we can't do that tonight, right? So we just, we elbow it, we high five in the air, we do what we can. We have to stay safe, socially distanced. I want to thank Megan for doing this tonight. This was absolutely fantastic. I know the people in Roanoke greatly appreciated what we did here right now. Okay, and it still gave them the program that we were going to be doing live and in person, and we are doing this as a 2-day event. Megan will be back again tomorrow morning, okay? She is going to speak about the same things, but we have a whole new set of questions that are going to be coming our way because we have a whole new set of people that will be on virtually watching this program, okay? And so we're going to have fun again tomorrow morning, all right? And the program starts at 10:10 a.m., all right? So that's 10:10 a.m. Eastern Time. So if you want to share the link with anybody else that's out there, also for everybody that was on here tonight, I also sent the link to you if you want to register to be on for tomorrow morning. We would love to have you back again, all right? In the meantime, I want to thank you all for being here. I want to thank the people in Roanoke as well. Of course, Megan and our crew in the background here, all right? We did, yay, awesome, great work, okay? We'll see you all soon. Thank you.